tragus test is negative, and then we'll do otoscopy. So make sure, like whenever you're doing any station, if there is any contraindication, rule it out. Otherwise, problem. Like for the fundoscopy, that glaucoma and the eye drops and all. For this, make sure you do this tragus test. Yeah. Then we have to do otoscopy. So how we do otoscopy? So this is your otoscope. So how we will hold this? Yeah, this was like a ophthalmoscope is like a mic. This is like a pen, like you write. Yeah, this is how we hold it. And what else we do is we keep our little finger on the patient's cheek like this. This is the perfect way to keep our little finger on the patient's cheek like this. And with the other hand, you will way to hold the spin upward and backward. Why we keep this little finger on the patient's cheek? Just to support, and maybe like patient can move his head maybe suddenly, and we might poke this earpiece very much like inside. So this is how, just for the support, we just hold it like this. This is the perfect way to hold it. Hold it like a pen, like a pen. Don't hold it like this or something. Way to hold it like a pen. Hold it like a pen, like a pen. Don't hold it like this or. So if it is right here, it's like this, and if it so if it is right here, it's like this, and if it is left here, then switch hand and like this. In this, there is one ear. GMC Mannequin has got both the ears. I don't know from where they bought that one. This will be tilted in the exam also, but if in the exam, if there is both the head, then both the ears, then how it will be tilted? Actually, the head is flexible. You can just put there. In this, they just gave this body actually. It was like this only. But just to make it a bit tilted, because whenever we do otoscopy, the head should be a bit tilted. This is that's why they have given this one. But in the exam, that the head is actually a bit like flexible. It will go that way. It will come this way. So how we do otoscopy now? So after you have done everything, done with the patient, you have done inspection, you have done palpation, you have done the tragus test. So now we'll do the examination on the mannequin. This is wrong. Okay, so how we simply you can tell the patient, so now I'm going to do the examination on the mannequin. That's it. Thing is, you should not poke this otoscope in the patient's ear. Just go for the mannequin. Simply say, now I will be doing my examination on the mannequin. Excuse me for some time. That's it. So now again, just make sure if the mannequin has got light or not. This mannequin has light inside, so you have to switch off the light of your instrument. Otherwise, you will not be able to see anything. Actually, you can try also. You won't be able to see anything if you switch on the light of your instrument. If you switch it off, then you can see it because the reflection. So if the mannequin doesn't have the light, then you have to switch it off. Switch it on. Yeah. So how we'll check it out? So what do you think? What can be the finding in the mannequin? Because patient is giving the history that I'm having this ear pain, I'm having fever, flu-like symptom for last 1 week, and no hearing loss, no weakness of any part of the body, no ringing sensation, no rash, photophobia. So what it can be? So see, patient said, I have pain in my right ear. Yeah, so let's check the right ear. We can switch on the light and you can just check this external auditory canal, and just you can comment on if there is any foreign body or any wax. With the light, there is no foreign body and no wax. Now I'll be inserting the instrument inside, and then you have to check it. And you have to check it whether it is red or it is normal. So when you are holding it this way, you have to comment it. If it is normal or it is otitis media. See if you can see something. So in normal tympanic membrane, what you used to see? What you will see? What's the normal color of tympanic membrane? Pearly gray, yeah, pearly gray they say. So I can see tympanic membrane which is pearly gray. What else is visible in tympanic membrane? Light reflex, yeah, that you can see at roughly at 5 o'clock position. Light reflex, or cone of light you can say. You can see umbo, you can see handle of Malleus, and pars tensa flaccida, everything is visible in normal tympanic membrane. But if it is otitis media, what you will see, you will just see redness everywhere. You will not be able to see all these structures. You won't be able to see umbo, handle of Malleus, or cone of light, or pars tensa flaccida. It will not be visible. What you will see is just the redness, Yeah. So you will be able to see only the redness. So you just have to comment. I can see there is tympanic membrane is red, congested, inflamed, edematous maybe, and I cannot see umbo, cone of light, or handle of Malleus. My most probably diagnosis is otitis media. That's it. What you can see. Huh? See once more.
In other words, I went to seek help, but it didn't work.
Yeah. That number 2 is normal, number 10, 11, they are otitis media. You can check it out.
I wanted to cut down. I went to alcohol anonymous.
Yeah, normal. You sure? Definitely.
Well, yeah.
I know.
Now I see everything matters.
Sure. So maybe 1 or 2 of you should come quickly, and then after the class you can see 1, 2 of you. Achoo. Come. So the patient is having pain in the right ear. So where we'll start, from the right ear or from the left ear? I mean, usually in a real practice, you'll start with the unaffected ear, but here again, you can start with the affected ear for the time stop here. So, yeah, see, tell me what you can see. Maybe don't insert it too much, you won't be able to see it. Can you see something? Purple or red, whatever it is. Yeah, okay. Yeah, so nothing else is visible, actually just the redness is visible. Let me change it just a second. Pale one. If there is, then you see the cone of light at 5 o'clock and it is a bit pearly gray. Yeah. So that is normal actually. This is how you can differentiate. See, I mean, don't expect too much from the mannequins, yeah. But you will get to know if it is normal or not. Yeah. So this is, and even if you are not able to see anything, you know, patient is giving me the history. I have pain in my right ear, so right ear is otitis media. That is normal. That's it. What you are expected to see in the right ear, you will see otitis media. You will see red, congested, inflamed tympanic membrane, and you won't be able to see anything else. For example, the cone of light or the umbo handle of Malleus. You won't be able to see anything. What you see is just the redness, and the redness. And if it is normal, say I can see all these structures. I can see tympanic membrane, which is pearly gray, and I can see all these structures like umbo or this handle of Malleus and the light reflex, cone of light. So my most probable diagnosis is normal tympanic membrane. Yeah, see, when you are doing this, so if it is otitis media, for example, the right ear I'm checking, so you are verbalizing, I can see tympanic membrane, which is red, congested, inflamed. I cannot see handle of Malleus, cone of light, umbo. My most probable diagnosis is otitis media. Say, when you come back to the patient, then you will explain that you have otitis media and you will tell about the management. One thing that you have to make sure in this patient, don't forget about it. You have checked the right ear. It is a right media. When you are going for the other ear, please change the earpiece.
I did not know what symptoms the cross symptoms are, right? I love them.
You'll be having lots of earpieces in the exam, so just change it, yeah? Change it. Put this in the other kidney tray and pick the other one and fix it, and then do the other ear. Don't infect the other ear of the patient as well. Yeah, you can do, but it depends on time actually. If it is normal, still you can change it. Fine. Still you can change it. If they have only one, simply verbalize. Ideally, I'll change the earpiece. Verbalize. But they have like lots of earpiece. So just change the earpiece. Please do not forget to change the earpiece when you are examining the other ear. And don't forget the tragus test because that is a contraindication. Yeah, just put it in the kidney tray. They have to use it for the next candidate. Don't throw this stuff. But yes, just discard it. There will be kidney trays. Just put in the kidney tray. That's it. This is what we do. But please change it. It's very important. Don't use the same for both the ears. Yeah. So again, switch it on, switch it off from here, the same. And this is the one they usually give in this otitis media, the otoscopy. This one they give in endoscopy. So this is switch it on, switch it off. How we hold it, it's like a pen. Like a mic. Like mic. And this is like a pen, the otoscope, like this. Yeah. So in this, both the findings are normal. In this, you will get 1 year which is otitis media, 1 year which is normal. And you know which ear is otitis media, which has got pain. Usually they give right ear, whatsoever. And you'll be able to see, actually, you'll be able to see everything in these mannequins. But again, don't expect too much, from the mannequin. Of course, at the end of the day, they are mannequins. Sometimes when you're doing the inspection, you're doing the palpation and all those stuff. Examiner might say, doctor, do the inspection palpation on the mannequin. So that's also fine. You can do it on the mannequin. But make sure that first you will go for the patient, for inspection and palpation, not for the otoscopy. Otoscopy directly go to the mannequin. But inspection, palpation, go to the patient, do it. But sometimes they might instruct you. The examiner might tell you that doctor, do it on the mannequin. And inspection, palpation, also do it on the mannequin. Yeah? Follow the command, whatever they say. Palpating the ear of that's it. Yeah, so that's the patient. See, your patient will be sitting here only. It's not like patient is sitting too far or something. Patient will be sitting here, so you're giving the command to the patient. Never talk to the mannequin. Yeah, never talk to the mannequin. It happens, like we sometimes struggle like whom we are talking to. So never talk to the mannequin. Patient will be sitting here, but it happens like 40 candidates doing this. Maybe he's right now tired or something. They might tell you. Actually, nowadays they are telling it. Like, do it on the mannequin, not on the patient. So then you can do it on the mannequin, simply like, what else can be done? Don't talk to the mannequin. Don't say, so I'm going to touch you. Something like, no. If patient is there, tell it to the patient. Yeah, you are telling it to the patient. Yeah. I know a bit awkward stuff. I can't say anything, but they say don't talk to the mannequin. That's the thing. So try avoid. Don't talk to the mannequin. No, it's fine. Try to minimize the use of this. Ideally, they don't like. I'm also trying to minimize it. Where it's very much necessary, I'm saying, otherwise I'm not using the word. Even some says like, we just examine 1 ear or 1 eye. So I would say, instead of you say that ideally I'll check the other ear or ideally I'll check the other eye, you just go and check it and say it's normal. How much time it takes? It's going to take same time. Isn't it? I have checked right ear. I'm saying it is otitis media and it's 6 minutes bell. You will say, ideally I'll check the left ear. But what I will do, I'll go and check it and say it's normal. I think it's going to take same time. That would be much better. I will say try to avoid as much as you can this word ideally. Do instead of saying ideally. But there are some situations that you have to say ideally. For example, there will be a lot of things. It will come like exposure and all. You need full exposure, but patient is wearing short. They will say, examiner will say, doctor, ideally assume exposure is. So I mean, you can't do anything in that situation. But if you can do something and you can avoid that word, I would say avoid it. Do it. Yeah. And then what's the management in this case? Pain relief and PI, antibiotics. Antibiotics. This patient is allergic to penicillin most of the time. Is it mentioned in the script or not? Yeah, this man and UTI BPH man, they both have allergy to penicillin. So make sure don't give them a penicillin. Yeah, he's allergic to penicillin. Same here, fourth day. This patient is giving history of fever and all those stuff for last 1 week. So you will give antibiotics. Yes, so which is the antibiotics you will give? Amoxicillin, this is, but now we will not be giving because it's allergic. And erythromycin, post-erythromycin can be given to this patient. Nobody is going to ask you the name of the drug actually. And you will be having DNS, so you can simply address that thing that you told me. You gave me the history that you're allergic to penicillin, so we'll take care of that and we'll give you some other medication. More than enough. If they are forcing you, you can tell erythromycin, that is 500 mg QDS 5 days, or critical erythromycin 500 mg PD for 5 days. If you don't know the name, you can open the book as well, or you can say, I will consult with my senior and will give you antibiotics according to the hospital protocol. It's up to you. No problem at all. Don't take it that much seriously, the name of the medication. And give the warning sign of otitis media, meningitis, or any discharge from the ear. So you can give these warnings. And if you have some hearing problem, any discharge from the ear, any rash, photophobia, please come back and keep following us. Follow up. Yeah, easy patient. So make sure change the earpiece when you're examining the other ear, and please don't miss tragus test. Very important. Any patient, before you do the examination of mannequin, think in your mind if there is any contraindication or not. Because small mistakes, okay, fine. But if it is a big mistake, then it's not good. So for example, if we are not doing tragus test and simply going proctoscopy, doesn't fine. To make sure rule out contraindication for sure. Yeah.
And the examiner did the examination on the mannequin. So we have vocalized.
No, say, I mean, okay, so tell the patient, okay, now I'll be just touching one part of the ear. If you have any pain, let me know. Touch both the tragus and say tragus test is negative. You can do it, and yeah. But make sure when you're doing otoscopy, don't wait for the instruction from the patient. Do it on the mannequin only. In the mock, the blood test, they were coming to the simulator. Okay, I mean, come on, you cannot do the blood test on the simulator like 40 candidates if they will do like that. It's not like always they will tell you to do it on the mannequin. You should go yourself. For example, in this station, don't do inspection palpation on the mannequin. First do it on the patient. But if examiner says do it on the mannequin, that's a different issue. But for otoscopy, you don't need any instruction. Just go for the mannequin. That's it. You simply say, okay, just excuse me, I'll be doing my examination on the mannequin, and just go for it. Usually they will also guide the examiner, the patient is also. They will do the, what do you say? They will tell you, some gesture like do it on the mannequin. So just see what things you can do on the patient, do it on the patient. Well, things which cannot be done on the patient, do it on the mannequin. That's it. And if they say something like, for example, inspection, do it on the mannequin, then do it on the mannequin. There is no point of arguing with them. Yeah. Okay, there is, let's do one more. Who will take the history? No one? I mean, just sitting at your place, just you have to take history. patient is a female patient, 50-year-old, presented to the hospital with problem in the ear. And this is the first time she came to the hospital, talked to the patient, and discussed the plan of management. Sorry? Take history. There's a problem in the ear. 50-year-old female patient.
So when we have non-medical options, we have medical options. We will not just
Yeah.
go for medication, we just not go for non-medical. We have a
Yes, good afternoon. All right. Doctor, I have a problem in my left ear. I cannot hear properly. I started, 2 weeks back. Sorry? Like what? No, there is no pain. No fever. No discharge, doctor. Yeah, no, I woke, I feel a bit like uncomfortable, like, yeah. No, fortunately not. No headache. No. No weight loss. No appetite loss. Like what? No ringing. No fullness. Sorry? Yeah, I feel wobbly. I feel unsteady when I'm standing. Yes. No numbness, doctor. No fullness. No ringing sensation. No cough. No flight. No swimming. Other ear is very good, doctor. Fine. This is a very important question. Same in the eye, when a patient is saying one eye lost, vision loss, ask about the other eye. Same here, one ear he cannot hear. Ask what about the other ears. Anything else? Sorry? Not complete loss. It's difficult for me to hear, but not complete loss. What type of word? Office job? No, doctor, I'm not taking any. It's the same, I would say, but not. 2 months, did I say 2 months? No, it's the same, Double vision, no, doctor. Why? So which differentials you rule out? You ruled out so many. Venous, you ask. Acoustic, can it be acoustic neuroma or not? What will the symptom signs you will get in acoustic neuroma? But if you have these two findings, if patient is unsteady, wobbly, and if patient is having hearing loss, that is actually sensorineural, maybe if it turn out to be, think of acoustic neuroma as your first differential. The unsteady, the balance problem. Patient is feeling wobbly, unsteady, and hearing loss. Think of acoustic neuroma. No, doctor. No. No infection, no fever, flu-like symptoms, doctor. No cough, no ear discharge, no ear pain. No double vision, doctor. No surgical procedure in the ear. No medication, no nothing. No allergy, nothing. I can't hear it. It's fine. No, doctor. No. What a toxic drug, no, doctor.
Right now, but no, I
Yeah, you can feel, you can ask like any sound which others feel okay, but you feel like it's too much for you. Yeah, it bothers you a lot. That you can ask. So the thing is, why these two stations they are asking? The first patient, the patient was giving the pain, fever, no hearing loss. This patient is clearly saying no fever, no pain, only hearing loss. So actually, what they want you to do here, hearing test, of course. But in what will happen? This tuning fork, they are keeping here. The mannequin will be there and the instrument, everything like this. This is the setting in the exam.
We will have a lot of questions which we think are fine. But what happens is if you are talking about the setting,
This is the setting. Usually they are, I don't know why they're keeping it at the back or something. Maybe. What do you think? I mean, if patient is giving you hearing loss, definitely you have to do hearing test. Yes, even if you want to miss otoscopy, you can miss it if you don't have time. No problem at all. But definitely you cannot miss hearing test, isn't it? In this patient, take this history, rule out the things which we have ruled out, and after that we do the examination. The examination the same way we do. First inspection and palpation. Even triggers test, but after that you have to see the time. If you don't have much time, skip otoscopy. Don't worry about otoscopy. That is not that important. What is more important is this hearing test. So when we did the peripheral vision, we did visual acuity. Can we do auditory acuity before we do hearing test? Yeah. So tell the patient, I'm going to your back, and I'll be rubbing my finger. You just close your eyes and tell me which ear you can hear.
Right there. That's there.
All right, fine. You can open your eyes. Yeah. And then we'll do the hearing test.
Obviously, you don't know what is the next part.
Let's do the hearing test.
What we can do is we can make an environment.
So this is what you have to pick. This is 512. So we'll do Rinne test and Weber test. So first we will do Rinne test. So how we'll instruct the patient. Yeah, this is a tuning fork. This is a buzzing instrument. They usually say the 128 one is a vibrating instrument and this is a buzzing instrument. It's better to use the word buzz. So this is a buzzing instrument. I'll buzz it. So you can buzz it like this or hit your bone. Because if you hit here, it will not buzz. You have to hit your bone. Yeah, or you can just hold the two prongs and that's also can be done. It's up to you. Or hit your bone. So I'll buzz it. I'll place behind your ear, in front of your ear. So you can give the instruction. I mean, there are two ways to give the instruction. Both are right. So I'll buzz it. I'll place it behind your ear and in front of your ear. Tell me where you can hear better, in the front or at the back. That is fine. Or you can say, I'll buzz it, I'll place it behind your ear. When you are not able to hear, tell me, then I'll bring it in front of here. That is also fine. Both the instructions are fine. There is no wrong, no right. Both are fine. But the first one will be, I think, better. You can do it quickly, actually.
I know what you're talking about.
So what you have to do is, buzz it and place it behind the ear. Let's hold maybe 3-4 seconds. Where? Better in the front. Alright, so I'll be doing the same in the other ear.
Either you are in past, you are in the future, be present, no, Baba. I know what you're talking about. Okay, I'm not done.
Front, okay. So what is the Rinne interpretation, how we interpret? Normally what happens, air conduction is more than bone conduction or bone conduction is more than air conduction? Air conduction is more than bone conduction. So that is Rinne positive or negative? See, whenever we say like any test positive, it means there is a finding. But this is opposite actually. Rinne positive means Rinne normal. There is no finding at all. So the finding he gave me, air conduction is more than bone conduction in both the ears. So that means Rinne test is positive. Sorry? Yeah, that is what I said. You can give that instruction also. Both the instructions are fine actually. That will take a bit of time. If I'll say, I'll buzz it, I'll place behind your ear. When you are not able to hear, let me know. Then I'll bring it in front. So you can give that instruction. That's also fine. It takes time. That's also right. No problem at all. Whichever you want to do, you can do. Both are right. But it takes a bit like more time. That's the only thing. So if you just keep it for 3-4 seconds and just bring it in front. If he is able to hear better, air conduction is more than one conduction. Rene is what? So Rene positive means what? And what's the interpretation? Here is normal. It might be normal. It might be sensorineural hearing loss. Let's confirm it by doing a Weber test. So Weber test, we will give the instruction to the patient. I'll buzz it again. This time I'll put it on your forehead. Yeah, on a forehead, and tell me where you can hear better. Right ear, left ear, or both the ears the same, or you can't hear anything. Yeah. Anything right or left?
I feel scared to say.
I know. Because you are normal. That's why I said say right or left, whatever you want to say.
I can hear it more on the left.
So patient can hear more on the left side. So what's the finding now? See, Rene was positive in both the ears. So that means it can be normal or it can be sensorineural hearing loss. If patient says I can hear in both the ears, it means patient is normal, no problem at all. But now my patient said I can hear better on left side. Actually, Weber lateralized to opposite side. So this patient has got right side sensorineural hearing loss. Yeah. Okay, we'll repeat 2-3 more. I'll give finding, just tell me which is this finding. In front, in the back, left side. So, yeah, if anytime patient says bone conduction is more than air conduction, so in that case there is definitely a conductive hearing loss. Let's confirm it by doing Weber test. But this time Weber will lateralize to the same side. In sensorineural, it will lateralize to opposite side. Yeah. Let's do one more. In front. In front. Right side. Left side sensorineural. Yeah. Any problem? One more or fine? Okay. At the back. In front. Okay. Left side.
Right side conductive and left side sensory hearing loss. Right side conductive hearing loss with a sensory. And a sensory on the left.
What was that? Yeah. Okay, I'll repeat it again. What I said here in the back. All right. Okay. So come back. At the back. In the front. Left side. Right side conductive. Right side sensorineural. The right side makes hearing loss. It's very difficult to interpret with this. Right. But actually, see, the thing is, it's very difficult to interpret only with this instrument, the mixed hearing loss. In the exam, what they are giving only the sensorineural hearing loss. But after you have done, you have to interpret it nicely. You have done Rene, you have done Weber, then you have to say, my patient has got Rene positive in both the ears. That means air conduction is more than one conduction. And the Weber lateralized to the right side. So my patient has got left side sensorineural hearing loss. You need to say full line. You need to interpret it for the examiner. not for the patient. For the examiner, you need to interpret. Yes. Which one? Last one, leave it actually. I'll give you the other one. Just tell me what's that. Easy one. At the back. In front. Right side.
Always be your friend.
Right. It's right conductive. Huh? Little I said right, I said. Right. Right, I said bone conduction is more than air conduction. Left, I said air conduction more than bone conduction. And left, I said right here. So it lateralizes to right side. It will lateralize to same side if it is conductive hearing loss. It's conductive hearing loss in the right side. But yeah. Yes, so after I have done my examination, I have done Rene, I have done Weber, then I'll verbalize for the examiner. We are just, in all the stations, we are not looking at the examiner, we are just doing our thing. Simply you are standing, you have done the Weber test, so where you can hear. So for example, you said left side. So my patient has the Rene positive, you can say. In both the ears, air conduction is more than bone conduction, and Weber lateralized to the left side, so my patient has right side sensitive hearing loss. And then you start doing the further examination or the management whatsoever. In all the station, you need to verbalize the finding. So he will be knowing, yes, that this candidate knows how to interpret the finding. And Rene positive is normal. There is no finding at all. Because it happens. When something is positive, you think like there is some finding, but not there. First on the patient, but if examiner says do it on the mannequin, then do it on the man. Then examiner or the patient will give you the finding. Don't worry, follow them. See, this is not invasive, nothing at all. So you can do it on the patient, yeah? So do it on the patient. But this mannequin is there also, in their station also. So if examiner says do it on the mannequin, do it on the mannequin. Someone will give you the finding, maybe the examiner, maybe the patient. That's not your headache. You will get your finding. And it is usually sensorineural hearing loss. And you know which side, because patient will tell you in the beginning itself, doctor, I cannot hear from my left ear. So you know what you are going to get in the finding. Because that should synchronize. The history and the examination, it will match up. So you don't have to worry. It's not give like I cannot hear from the left ear and the finding they are giving for the right sensitive hearing loss. That doesn't make any sense. So they will match it up. This Weber is not positive. It will electrolyze to some side. It is normal. If Rene is positive in both the ear and Weber is not electrolyzing, it's normal ear. Like, it's normal. That's why I said in the beginning, I can hear same because it's normal. It will electrolyze if there's any problem. Doesn't matter sensorineural, it will electrolyze to opposite side. In conductive, it will electrolyze to same side. Yep. But otoscopy, you can skip it in this case. But yes, and the message will make sure you will find it out from somewhere. Yeah. After doing this, you can, if you have time, this is the core of the station. Definitely you have to reach this point. But if it is not 6 minutes, you can go for some further tests also. You can do Romberg test or you can do marking test as well for checking the labyrinth and all. Romberg we know how to do is, let's do marching test. Are you able to stand up independently? Could you please stand up for me? Thank you. So marching, how we can do marching test? So tell the patient to stretch the hands like this. Start doing the marching on one side. Close your eyes. Relax. Relax. You can open your eyes. Have a. What will happen? If patient is doing like this and if patient moves, there is a finding. There will labyrinth lesion. Which side? Which side the patient will move? Towards the side of the patient, left side. For example, if I am moving on this side, right side, lesion of the labyrinth, you will not be able to reach to this point actually because there is a lot of stuff in the beginning you have to do, the history, the inspection, the palpation, the hearing test. And then if you have some time, you can go for this stuff. I mean, the Rombergs and the marching test is for, because patient is saying the balance problem also with the hearing loss. So you can do this test as well. Marching. Again, like to remember it, how to, it's like thumbs up. So this is how you will remember it. And start marching first. You can instruct the patient. You can also do with the patient. Yeah, first this one, start marching and then tell the patient to close the eyes. So after closing the eyes, maybe patient will move to one side. But in the exam, he will not move. He'll be fine. So till this point, we can do it. Yeah. So the management, what will be the management in this case? And you should know how to put it because usually in the exam, they give it like this. I mean, for the otoscopy, you need to put a constant yourself. You should know how to fix it. Yeah. So management is, what is the management of acoustic neuroma? It's irreversible. What? Hearing aids we can give, but see, if it is a acoustic neuroma, and if you remove that tumor, is there any chance that something will come back?
No.
Yeah, hearing, the treatment of this hearing loss is hearing aid actually. And what is the treatment of this acoustic neuroma? Surgery, but actually it depends if it is giving too much symptoms for the patient. Because it is actually a benign tumor, not that much like aggressive. So keep on doing the investigation like CT MRI regularly, CT we do, and just see the size. If it is growing and creating some problem for the patient, we remove it. Hearing loss is, you have to manage with the hearing aid. But yes, if the tumor we take out, there are some slight chances, maybe a bit of hearing might come back, but the final treatment is only hearing aid. But don't say 100% no, yeah, no, nothing will come back. After the surgery, there might be slight chances, not like fully recovery, but a bit of improvement may be there after removing the tumor. But straight away, we are not going to remove it. And please tell the patient to inform DVLA. So you can ask maybe in the history also, or maybe just in the management, you can tell if you're driving, please do not drive, and please inform DVLA. Yes, this is a tumor, but it's not that aggressive tumor. You can do actually eyes actually maybe, but patient will not tell you because patient is not thinking that his hearing loss might be cancer or something. But then you can reassure the patient it's not that aggressive tumor. It's like a tumor which doesn't spread, and we can follow up with you. We can do some investigation to find out what is the size, and there is no need for the treatment. But if it is too big, then we might have to do some surgery. But it is not aggressive. You can reassure the patient. And for the hearing, because we have to do the symptomatic treatment, because patient is feeling some trouble with the hearing, so hearing aid. But patient is having some balance problem also, so maybe we have to do surgery. We don't know at the moment. We need to do investigation. So don't comment on that much, like what is the plan. Just say further investigation. Only then we can comment. For hearing, yes, hearing aid. So in this station, if you get time for otoscopy, you can do, but I would just skip the otoscopy. It's better if you do marking test and all. I mean, but still don't force yourself. Rene Weber is a thing that definitely you have to. Please do not miss Rene Weber. If you want to skip otoscopy, skip it. No problem at all. Do auditory acuity and do hearing test. After that, if you have time, go for Romberg and marching. That's it. If you don't have time, go for management. Management is very important. Yes? Yes. All right. See, these two things, if it is there, we are suspecting it might be. And if you have this sensorineural hearing loss with balance problem, wobbly feeling, first thing is acoustic neuroma. Yeah, we will investigate, but we are suspecting it is acoustic neuroma. And see, it's not a very big thing. It's treatable stuff. So say it.
So, if the right prime is negative and it lateralizes to the left, then it's the right next.
Say again.
So, right Rene is negative.
Right Rene is negative.
Yeah. And it lateralizes
Okay.
to the left.
And it lateralized to the left.
Then it's the right next.
Yes. Yes, that's she's right. She's right. Yes. But don't go for that mixed hearing loss. It's very difficult to elicit only with the help of tuning fork. But But yes, you are right. So in the exam, they are giving actually this sensory neural hearing loss. Let's do one more last station for today, then we'll practice. Oh. Which one? BLS. Okay, it's a teaching station actually. Open it and read the question. You are F2 in general medical ward. Alex is FY1 who has missed his BLS classes. So what you have to do is you have to teach Alex about the BLS and assess and give him feedback. This dummy will be on the ground actually. So we have to kneel down on the ground in this station. No. If you have any patient who is collapsed, so what you will do first, you will pick him up and put him on the couch, then you will do CPR. So this dummy will be on the ground, so you have to be strong. And you can try doing this. It's not easy. And think about Alex also, he has to do 40 times. It's not easy. And this Alex is very cool. Need to involve him, otherwise he will just take his phone while and start playing on some video games or something. You need to involve him. And he's very nice, something just not standing, okay doctor, all right, something like this. And then say, okay, come down, and he will lie down on the floor like this. It can happen. So be ready for this kind of thing. And like wearing jeans, t-shirt, and very cool dude. Not standing even like this, no, very like dancing on one place, something like this. You have to test actually how you teach. They infuse a lot of teaching station now. They want you to teach the student in a sequence and involve him also. I mean, if you're not giving him eye contact, you are just busy doing it. You're not giving him eye contact, then he will lose that interest, and he will do the stuff what he wants. But if you properly make an eye contact and all, then he'll be okay. He'll be fine. So before you start this station, actually, any teaching station, the first thing is making a rapport. You have to make a rapport with the colleague. So as we made with the Wilson, just have a chat with him for a minute, which is of no relevance, but have a chat. Hello, Alex. His name is Alex, actually. How are you? Not bad. How's your hospital posting?
So basically, when I ask everyone,
it's pretty much fine. Any problem? Sorry? Oh, that's fine. That's great. Is there anything that I can do for you? Yes, why not? I'm here to tell you about BLS. Don't worry about it. After this session, you'll be fine. Yes, definitely. So you just have to have this kind of chat that make him comfortable, make him like your friend. Yeah? Why? Because he was unattended. So after that, we have to start this thing. So first, what we do first, you can make a mnemonic actually. I have here my doctors ABCD or SABC. What is D? D is danger. R is response. S is shout. A is airway, breathing. T is call, and then circulation will come. Chest compression and the rescue breath. This is according to the UK and European resuscitation guidelines. They don't check pulse. Don't ask me why they are not checking pulse, because this is their guideline. They follow it, and that's why we have to follow it. Don't ask me why it's like that. It is like that. So this is a mnemonic against the doctor's ABC. It's a bit different from the American guidelines. This is according to UK and European resuscitation guidelines. Doctor's ABC. These dangers. R is response, then S. You have to shout for help. A is airway. B is breathing. T is call. After that, you will do chest compression, rescue breath. So make sure we know these steps. Don't mess up with these steps. Yeah. So who would like to learn? Who are you, my student? Alex. Alex, okay, come Alex. Alex, then you have to teach also to all the class. I teach you, and you teach the whole class. Okay. So first, just you have to have that chat like, how are you, this and that, yeah, and then we will start this. So always assess the knowledge. Good quality of voice, which is very important. Yeah. So first, always assess the knowledge of your colleague. Yeah. So Alex, do you have any idea about BLS?
I know it's chest compression.
Yes, yes.
I know you have to breathe into the mouth.
That's great. I'll tell you in detail. So BLS actually, BLS stands for basic life support. And this is the thing he knows actually. Once you ask, do you have any idea about BLS? Yes, doctor, it's basic life support. So always encourage, because whatever he knows, just give him compliment. Oh, that's great. Yes, this is basic life support. So what we do, why we do, each patient we do BLS.
Patients who are unconscious.
Yes, absolutely right.
Patients where I can't feel pulse. Patients who may have difficulty breathing.
Yes, the patient who are unconscious or those who are not breathing or not breathing properly, these are the patients where we do this basic life support. So how we should start? So first of all, Alex, make sure, just one more thing, what we do in BLS, that also a brief explanation you can give actually. So what we do in BLS is, we give chest compression and we give rescue breath in order to take over the function of heart and lungs. So this is BLS in short. See, you can give explanation for 5 minutes, but the thing is, in total you have 6 minutes, because you have to assess in last 2 minutes. So it should be in a brief. First, make a repo half a minute or 1 minute whatsoever. Then ask him how much he knows. He knows only BLS is basic life support. He doesn't know more than that. Then after that, yes, this is basic life support. And we do in those patients, those who are unconscious and those who are not breathing properly. So what we do in BLS is we give chest compression, we give rescue breath, just to take over the function of heart and lungs. Okay, Alex? So before we start this procedure, make sure of safety. There should not be any danger. Safety of our victim, our safety and safety of the bystander. For example, if patient is maybe the victim is in the middle of the road, we cannot do the chest compression there. We have to have our patient on side. Or maybe if there is any live wire or any sharp object, so make sure you take your victim away from that. So first is avoid danger or maintain the safety. That was the first point. Yeah. And then we have to check the response of the patient. So would you like to join me? Yes. So sometimes what happens is you are kneeling down and your Alex is standing and you are making eye contact like this. It's very difficult. So tell him, come down. Yeah. So after that, once we have made sure there is no danger at all, so we just quickly see. Hello, hello. Can you hear me? Hello. So what we do, we check response. After that, if there is no response, shout for help in all 4 directions. Help, 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 help. Yes. Yes? So after help, then we have to check airway and breathing. But don't waste time in doing the airway and breathing. Be very quick. Don't waste more than 10 seconds. All right. So how we check airway? There is a maneuver, simple maneuver. Head tilt. This hand tilts the head. Chin lift. Head tilt, chin lift. You have to lift the chin with 2 fingers. But make sure these 2 fingers should be on this bony area. Not on this soft area. Otherwise, you know what will happen. Okay. So the thing is head tilt, chin lift with 2 fingers. Yeah. And then we have to check for breathing. So keep maintaining this and check for breathing. So what we'll do? We'll look, feel, listen. We look for chest rise. We feel for breath, listen, the breath sound. So this is our breathing. But make sure, as I mentioned, please do not spend more than 10 seconds. Every single second counts. So we have to be a bit fast. Yeah. So after that, the next step is after you're down airway breathing, then you have to call. We have to call 999. But as you know, we have already shouted for help. If someone is around, you can tell them they will call 999 and ask for ambulance, ask for AED. AED is an external defibrillator, automated external defibrillator. That actually is there in the, you can get in the, anywhere actually nearby. So maybe if any help is there, they will call 999. But if there is no one, then will you do call or you do chest compression? So what you can do, take out your phone, put it on speaker and dial 999 and start doing chest compression. That is better, isn't it? But yes, definitely, if someone is around, that's always better. But if no one is around, then you have to manage your own, yeah? So what you can do is take out your phone, put it on speaker mode, dial 999, ask for help, ask for AED, start doing chest compression. Okay. Good. All right. So after that, we have to do the chest compression now. So explain everything in detail to the Alex. If you will miss something, he'll make the same mistake when you'll assess. So if you explain him well, he'll not make mistake later. So that's always better to do everything. So Alex, what we are supposed to do is, I have to put heel of our hand in the lower part of the sternum. Yeah. Interlock it with the other one. Make sure your elbows are straight. Shoulder is perpendicular to the patient's shoulder. So that means you have to give over the weight of the whole body when we are doing the chest compression. Yeah. The rate of the chest compression is 100 to 120 per minute. So you can say roughly 2 per second. And we have to give 30 chest compression followed by 2 rescue breaths. Yeah. And make sure when you're giving the chest compression, chest should go at least 5 to 6 centimeter deep. It's roughly 1/3 of the chest. Yeah. And do not lose contact with the victim's body. And give it enough time so that it can recoil. Yeah. And count it loud when you're giving the chest compression. All right? All right. We need to explain every single step. If he'll miss something, he will miss something in the assessment later. So, heel of one hand on the lower part of the sternum, interlock it. Make sure your elbow straight, shoulder perpendicular to the patient's shoulder. The rate is 100 to 120 per minute. That is roughly 2 per second. And you have to give 30 chest compression. That is followed by 2 rescue breaths. And give the chest compression so that chest should go to 5 to 6 centimeter deep. And don't lose the contact with the patient's body and give it some time so that it can count it loud. Yeah, so let me show you some. Then you have to show some. How many you would like to show? 30. Let's see how many. So just do it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 18, 19, 20, 21, 22, 8, 9, 13. Yeah. Yes, count out loud. So you have to count it loud also. So what do you think in the exam, how many you should do? Because it's not easy. So what you can do, at least maybe 15, and then tell Alex, but we should do 30. It's up to you. If you are comfortable doing 30, you can do 30 also. It's up to you. After that, we have to do rescue breath. So rescue breath, actually, they have some this kind of mask. And you will get like a different one for, once you have used throw it in the bin, the next candidate will use the new one. So you can put it on the patient's face. Don't mention about it because in the real life you will not get any mask near the victim. It's just for the exam purpose they have kept. So tell your colleague Alex, so now we have, after doing the chest compression, we have to give rescue breath. Yeah. So in rescue breath, what we have to do is, we need to follow the same manual that I told you earlier for the airway. Head tilt, chin lift, yes, great. I think that just to make sure one thing, you have to pinch the nose. You know why?
So air doesn't get out.
Yes, very good. So yes, air should not leak out. So just pinch the nose. And now you have to give the rescue breath. So we have to give 2 rescue breaths and make sure it should be a normal breath. Don't give a forceful breath. It should be normal breath. Make a tight seal, give a normal breath, and look for the chest rising. Yeah? I'm not doing, but in the exam you have to do it. Yeah? Yes? And after that, we'll start with the chest compression, and then we'll again with the rescue breath. Any idea like when we should stop, or should we continue till the...
We should stop once the patient either recovers.
Yes, absolutely.
Or after about 15 to 20 minutes or 22 minutes. So.
Why 15 to 20, Alex? Because if patient shows signs of life, then definitely you can stop. Secondly, if you are tired, just stop it. Yeah, if you are tired, why to do the thing which is not right? So stop it. And if help arrives, stop it. I mean, they can take over. Yeah. So now, could you please show me a bit of chest compression rescue breath? So don't tell him to start from the beginning itself, because that is just the subjective stuff. That is the thing that you are going to assess, the chest compression and the rescue breath. So could you please show me?
Sure.
Yeah. Okay, Alex. Encourage him. Don't accuse him. Yeah, continue. Alex, he's Alex. Yeah, go. Go. Yeah, Alex, you are doing fine, but it's better if you don't lose contact with the victim body. Yeah, right. Yes. All right. Yes. Count it loud. 1, 2. Yes, it should go 5 to 6 centimeters deep. 1, 2. 4, 5. All right. Yeah, how many we should do? 30. Yeah. So what do you think? In the exam, will you force him to do 30 or what do you think? See, usually what happens is he will stop after doing 10 or 15. So instead of forcing him, because he has to wait for 40 candidates, and if I'll tell you to do 2 times, you will struggle. Actually, it's not easy. So if he's doing 50, it's fine. Okay, Alex, good. So do you know how many we should do?
We should do 30.
That's great. So could you please show me now the rescue breath? You have confirmed that he knows that he was supposed to do 30 and move to the rescue breath. Please don't force him to do 30, but make sure he knows that he's supposed to do 30. Yes, great. What? Alex, you're not supposed to kiss for so long. You have to make a tight seal, and you have to give a normal breath and look for the chest right. And how many breaths we should give? 2 breaths. That's excellent. You did a great job.
Thank you. I feel so much more confident.
Yes, yeah, like this. Yes, the eye you can see it also, and this will move. So there is a bag, whatever, because they will connect it, and the bag is there. When you give the test, it will rise a bit, and the examiner sitting there can see. So don't fake it anything in the exam. And this station is more about making the reco actually. How we are talking to colleagues. Be very friendly. Spend some time in just talking here and there stuff, and then come to the topic. Assess whatever he knows. He knows nothing, just basic life support. And then you will teach him what is why we do it, which patients we do it, what's the procedure, and danger, response, help, and quickly check the airway breathing, head tilt, chin lift, 2 fingers on the bony area, and breathing, look, feel, listen, and then call. If there is someone, tell them to call 999 and ask for help, ask for ambulance, ask for AEP, automated external defibrillate. And if there is no one, you can take out your phone, dial 999, put it on speaker, and start doing chest compression.
In the exam, I just say that.
Yes. Everything, whatever we discussed.
Take out the phone.
Yes. If there is no phone, he has phone. You will not be having. They'll take your phone out. Just to tell and assess him. So you have to finish this station in 6 minutes, or maybe 6.5. I would just 6. Just try to finish it off. Whenever you're practicing about BLS, so practice like you have only 6 minutes, so that you can assess in 2 minutes. The mistake usually he is doing is for the chest compression, will stop. Definitely he will stop after doing 15. And sometimes he's a bit far from the victim and he's doing like, he's struggling. So you have to tell, come a bit close and give the force, from your shoulder. And then he'll be fine. And during the rescue breath, the common mistake he does is he will not face the nose actually. We have to tell, but always and say, oh, you are doing great, but that you will do this as well. So don't accuse him, oh, Alex, what you're doing, this is wrong. What did I teach you and what you are doing? So that's the difference. This is how we'll get good marks versus the passing. That's the only difference. It's not only about BLS, it's about communication between two colleagues. Yeah? Now choose your Alex and teach. Come on. Yeah, you can say that. You want to reach them, but you can't get them. You have to be very perfect. You have to show a smiling face, but you are not smiling from inside. No, we would have said, why you didn't attend your class? You should have attended. Why you came to me? I'm not going to teach you. Get lost. Yeah, that might be the stuff. So, usually what happens is Alex is standing here only. Maybe his body will be like this. Yeah, he's standing here. You will come and stand there and start. He might be standing or sitting on the other side, so that's okay. But here, maybe you can do like this. So one of you can come here. So it's okay. Yeah. Yeah. So start.
Hey, Alex, how are you doing? I'm good. How about you? How's work been? Okay. Not too stressful, right? No, not really. I've been a little busy. That's why I missed my BLS session. Okay, that's no problem. I'm here to teach you how to do BLS. Really? Do you know what BLS is? I think it stands for Basic Life Support. That's great. That's exactly right. So what else do you know about BLS? Not much. I'd be grateful if you could. Okay, no problem at all. Okay, so the first thing that you need to recognize, that you need to know about BLS is, if you have a patient, right, who would you perform BLS on? Somebody who's unconscious. Okay, that's right, that's one. Anyone else? Okay, that's fine. So it could be someone who isn't breathing as well. Okay. All right. So what would the first thing you would do if you found a person who isn't breathing? I'll go and assess the situation and check for his breathing person. Okay. That's not a bad answer, but the first thing you would do is check your area. All right. If let's say this patient or this individual was on a busy street, you would want to make sure this patient and yourself are out of danger. Okay, so you would want to leave the patient with all right. What else would you like to do after? Well,
and don't ask too much question also. You won't be able to you have already assessed me that I don't know anything. So it takes time, So yeah,
okay. The patient's there. We're going to see if we can get a response from the patient. Hello. All right. So should I go? Yes, you should come down.
Sometimes what happens is standing also throughout the station. If you'll not say, you will be standing. And then it's difficult for you to make an eye contact. That's the time he will take out his phone. He'll start playing.
Okay, so yes, you should come. Hello.
And don't also do too much of the thing because, so that in injury. So just tap on the shoulder, easy. Yeah.
Hello. Okay. All right. So you have the response. If there's no response, then I want you to shout for help. Okay. In all four directions. Okay. So help. Okay. You get that so far? Yeah. All right. And what you would do anyone standing by, you can access all 999 or get the AED. Okay? All right.
See, what he did is, okay, so what he did, he shouted and called at the same time. So you shouted now, after that you have to do A, B, C. A is airway, breathing, and then call. You know what happens is, what they really want is like, you shouted, help, 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 maybe someone is coming. It takes like 5 seconds, maybe they'll come. In the meanwhile, quickly check the airway, breathing. And then when he's around, the person, then just tell him about that calling 999. So that is the thing they want you to follow. That's why this the protocol is like that. And this is actually the graph, the chart that's on front page. This is what you're supposed to follow. Half of the things are there.
So now we're gonna check the airway. So we're gonna do this by doing a technique called the head tilt. So we're trying to right with the and the chin, these two fingers, and you can push it. And this opens the airway. Okay? And then after the airway we check breathing. Okay, so what you do is you put your chin right here. Feel the air. See the patient's breathing position, the breath sound, and you can look and see if the chest is resting. Right? You understand that so far? Yeah. Okay. And now, if the individuals around, we would call them. Okay? All right. And if there's no one around, you can simply take out the cell phone, put it on the speaker, and dial 999. What you continue. Engineer, to do what? This is where I'm getting to. Good question. Okay. You've heard of chest compression, right? Okay. So what you do is you take all of your hands, whichever hand you have, right? Put it right here, just right in the lower part of the sternum. Right? You take the other hand.
Just say lower part of the sternum. Actually, it should not be only on deep sternum. That might break also. Just say lower part of the sternum.
Alright. And you interlock. And then you make sure your arms are straight and your shoulders are square with the shoulders. Alright. And you push. So you compress. Yeah. So you compress down. Alright. And you have to do it when okay. And you have to comfort. Alright, so when you're doing it, alright. So what you will do is make sure when you're compressing, it goes at 5 centimeters deep. Okay? And allow it to recoil, but never lose contact with the patient. Okay? Do you understand so far? Yeah. Okay, that's great. That's great. All right. So I'm going to show you an example of chest compression. Okay?
Anything else you want to add? He said I'll go through it. He said, yeah. 30 to 2, just you can tell that. You already told like we are at a rate of 100 to 120, but you can say we have to do 30 per 2. That's it.
About 30 chest compression. And you ain't leave after that? After the chest compressions, we're going to do some rescue. I'm just going to show you how many 5 to 2 rescue. And then what are we going to do next? After that, we'll assess the patient. If the patient is conscious, then stop. If not, we will repeat. Okay, so we're going to keep assessing the patient after every 30 breaths, after every 30 compressions of the breath, right? So if the patient has become conscious, then we will need to do it. Okay, that makes sense to you, right?
Show him. Okay.
Alright, so this is just compressions, okay?
But in at least 15, do it, and we need to practice it. not that easy.
I know. That was 19. I know you get the gist. No, that should be
You don't need to mention the facial. Just put it, but don't mention anything about it. But because in the real life, it won't be there. So in real life, what you will do? I mean, if there's no ambush, someone you found on the road, what you will do? Yeah, if you're comfortable, go for it. Otherwise, just continue with the just impression.
Okay, so like I told you, how to do the either way, right? And in this scenario, you want to focus the classroom.
But why?
Why do you think? So that the air doesn't leak out of the nose. That's great, Alex. That's great.
Because then if you forget anything, I'll tell it.
Make it feel good. While I'm watching the chest, right? So we have to
Like tell the patient, like tell the colleague that make a tight seal, and you have to give normal breath and look for the chest.
Can we check chest rise while giving the question? I don't know. My eyes would be down on the.
You can. See his face like you can do it. It's not that tough. You can do it.
Don't worry, Alex.
In this, the chart we have given, it's recovery position, lots of stuff was given. You don't have, you just need to do till this point. I just copy pasted from the resuscitation counting, whatever they were. But this much is more than enough. And after that, tell Alex to do it. And if you have time in the end, you can tell Alex, you can ask Alex, do you have any idea when we should stop? And that's it. This is more than enough.
We will try, Alex. Yeah. All right.
Well, guys, we'll start 5:30 now, okay? So just take a break, and we're going to be starting with the history part of the OBG and pediatrics. Let's take up that point.
Brilliant. Yes, doctor. No, KMC does not have extra money to keep another complex. There is no other aspect. That's very good. I like with what you had, with the basic knowledge that you have been doing the entire day, you did very well. Now comes the core of the question. Okay. HBWD is very effective in alcohol. Okay. In